Hi, good morning, everyone. We'll start um, an online lecture about considerations for patients with tuberculosis in dental practice. This online lecture is for fourth stage students. Hopefully, it is successful, and if it is okay, we'll start new lectures with different topics according to what we have on the syllabus within the next week. Um, so as we said, it is the consideration for patients with tuberculosis in the dental settings. So in the beginning, what is tuberculosis? Tuberculosis, it is um, a disease, infectious disease that's spread worldwide and caused by Mycobacterium tuberculosis. Um, there are different types for tuberculosis. What is really matters in the dental practice, What is highly infectious and can spread by droplets is the pulmonary tuberculosis. We also have other types which are called extrapulmonary tuberculosis, like tuberculosis which can affect the lymph nodes, which is called TB lymphadenitis, and we also have tuberculosis that affects the bone. It's called skeletal tuberculosis. As we said, the mostly infectious disease is the pulmonary tuberculosis, and this is what we are going to talk about today. There are different clinical presentations. Some of these which can be manifested extraoral on the patient, like fever, malaise, unexplained weight loss, and night sweat. While for the sometimes, and if the patients have pulmonary tuberculosis, coughing would be specific for this type. Intraoral, also we can see an ulceration, as we can see here in the slides, ulcerations within the tongue, which can be characteristic, having those rolled margin. It's also painful, which makes it a little bit different from the rolled margin that we can see within the squamous cell carcinoma, which is usually asymptomatic. These ulcers usually painful. Other site for the oral ulcerations could be within the buccal mucosa. These ulcerations are sometimes associated with cervical lymphadenopathy. Okay. Moving from the clinical presentations, what really matters to us is the dental management for those patients. You can actually go to the websites, go through the lectures you have already taken for the general medicine, and you can get more information about the tuberculosis as a disease. What we are going to talk about today is the dental management of this disease, infectious disease, in our dental practice. Patients with tuberculosis can be categorized into different categories. Patients could fall within this category, which is clinically active sputum-positive TB. Patients could be having a past history of having tuberculosis. Other patients might have what we call a tuberculin skin test positive, and other patients might have sign and symptoms suggestive of an active disease. Within the first category, which is the patients with a clinically active sputum-positive TB, I mean patients who are infectious and already been diagnosed with tuberculosis. These are considered highly infectious. They have high rate for transmission of the disease from them to other patients or to the operator, him or herself. Those patients usually need to be treated in hospital setting, and those treatments need to be only for emergency treatments. Special precautions need to be adopted, means that the hospital need to be uh, fitted with a special ventilation system, and also the operators need to wear special protective equipment like gowns, eye protections, mask, and gloves. Patients within this category can convert to non-infectious stage. I mean, moving from being highly infectious to non-infectious stage, and still having the disease but can't transmit it to other patients or to the operator. This needs to start the treatment for a minimum of about 3 weeks, maybe, and you need to get a consultation from the supervising physician about the current status. If it is non-infectious and successfully converted to this stage, it can be treated as an outpatient. I mean, it can be treated within the dental practice. Children with pulmonary TB, even if they have a clinically active sputum-positive TB, children can still be treated as an outpatient. And why is that? Because children can cough effectively, so they can't spread the disease by coughing. But what would define a child? Because this is like an area of gray. Some would consider those patients can't cough effectively. Others would say no, they can't. So eventually, you need a consultation from the supervising physician about those patients, about children, whether they can be treated as an outpatient or not. For me, I would say if those patients, being children or adults, if they are clinically active sputum positive TB, I would say don't treat them unless it is an emergency treatment or the supervising physician have advised you that those patients can be treated without the risk of infectivity. Patients, moving to the another category about the patients with past history of tuberculosis. If the patient's given a history about having tuberculosis in the past, which have been treated, those usually can't be treated safely, proving that they have already received the adequate regime for this disease, and those are immunocompetent. An adequate therapy can be either or for about 6 months for the recent regimes, or about as long as 18 months for previous regimes. So, if patients have been recently treated and have received at least 6 months of a treatment, they are usually have received the adequate therapy. And about being immune competent, for example, patients on corticosteroids for long durations, patients diabetic, poorly controlled, these can be considered as an immune compromise, and their relapse of TB can happen. Um, Consultation with the physician sometimes might be needed just to consider whether these patients are immune competent or have received the adequate therapy. Otherwise, those can be treated as an outpatient and can receive the treatment as a normal patients. Patient with positive tuberculin test. A tuberculin test is a test where the health practitioner can inject tuberculin underneath the skin, and then the healthcare provider then can examine the site of injection for about maybe 48 hours or 72 hours later on, and examine the area that already have been injected with this material. If there is a raised area, they would measure it and determine whether those patients are tuberculin positive or tuberculin negative. Patients with positive tuberculin tests need to be referred to a physician to determine whether they have an active disease or inactive disease. Patient with positive tuberculin test means that they have been exposed to the microorganism, but the immune system might sometimes fight, and those patients can still be exposed but don't have the disease. So, I mean, they have inactive disease or what we call a latent tuberculosis. But if the patients have the active disease, they usually can't be treated and can't receive any treatment, as the patients are positive for the disease, which have high risk for infectivity only in hospital settings and only for emergency treatment. While for patients with inactive disease, it can't be treated as a normal patient with standard precautions for infection control policy. Patients with sign and symptoms suggestive of TB, this usually needs, like for example, patients reported night sweat, fever, malaise, and unexplained weight loss. These need to be referred to a supervising physician to determine whether or not they having the disease. This is all about the dental management for those patients. We still have some drug interactions between drugs that is used for treatment of tuberculosis and also for the treatment that we usually prescribe in our dental practice. For example of these interactions, we have the aspirin and streptomycin. Streptomycin is well known for causing ototoxicity. Aspirin, unfortunately, increase the incidence of ototoxicity of streptomycin, so their concomitant intake should be avoided. Isoniazid, also a drug for tuberculosis, can potentiate the hepatotoxicity of paracetamol. Paracetamol usually can cause hepatotoxicity in high doses. Usually within the normal doses, it can have this side effect. So isoniazid can potentiate the side effect of paracetamol of hepatotoxicity. So therefore, their concomitant intake should also be avoided. Low doses of paracetamol can be given safely, but the usual dose can't be given, as we said, isoniazid can increase the hepatotoxicity. We have included rifampin. Rifampin is also a drug that is used for treatment of tuberculosis. Rifampin can cause side effect that can be manifested within the oral cavity, which this include leukopenia, which can increase the incidence of infections and cause delayed wound healing. Thrombocytopenia increase the gingival bleeding. Thrombocytopenia means decrease in the level of platelets, and this might be manifested within the oral cavity as gingival bleeding. I guess this is all what we have for tuberculosis. So any questions you have, you can just send it in the comments below, and I'll be happy to answer them. Okay, thank you, and hopefully we can meet again next week.